So the operative words here are screen and monitor. And I'm going to talk a little bit about some differences between screening that we would consider for something like LASIK and then even monitoring progression for cross-linking and some of those differences. And this is just some of the safety disclosure information. I have no financial interest in topography or tomography specifically, except for my participation here today. So what's the real technology that we're using mostly in our clinic in evaluating patients for cross-linking is Scheimpflug tomography. And there's a couple of different ones that are out on the market. One of the ones we use a lot happens to be the Pentacam HR. And I want to say right from the there is a difference between refractive screening for post-LASIK ectasia, in order to do a LASIK case that's not going to lead to ectasia, versus monitoring progression in keratoconus for cross-linking. And for the screening aspect, it's really finding the tip of the iceberg, finding something that's before it really manifests itself so that you can safely perform surgery. And some of the things that I've looked at over the years, looking topographically, is just making sure there's no warpage or ocular surface disease, looking at the inferior-superior ratio, skewed radial axis, steepest K readings, all the things that you might normally look at topographically or change over time. And then I go on to the tomographic qualifications or indices, which are a little more advanced. Those are the Scheimpflug things that we'll talk about a little bit more as we go along. One of the things that was useful that came out a bunch of years ago was the Randleman criteria that basically broke it down for a LASIK case to say, is there a topographic abnormality, or is there some sort of a thickness, residual stromal bed, or amount of myopia correction that might, with the thickness, put it in jeopardy, and then, of course, age. And I kind of highlighted more topographic pattern and age because the other three sort of fit all into a percentage tissue altered, which has been one way that we look at it more modernly. But interestingly, a database came out recently from Steve Schallhorn in a study in Europe where they looked at 300,000 LASIK cases and 199 cases that developed ectasia. And they went back and looked at all the maps and the details, and they came up with odds ratios of what would be more at risk for LASIK. And of course, a form first keratoconus was the highest odds ratio, about 20-fold risk. The IS ratio in the skewed radial axis topographically that we usually looked at was at least a 5-fold risk. And if you took age, which was pretty significant if it was a young age, less than 30, especially down around 20 or even 18, and then linked that with the skewed radial axis and IS ratio, it was about a 12-fold risk. Interestingly, there was no correlation to percentage tissue altered in some of the thickness issues. Now, of course, if you go too thin, beyond the typical 250 minimum or 300 minimum, you may still have that risk, but all those surgeons respected those things, and that's why they didn't see the correlation there. So it's mostly shape and age that are the biggest factors. But then let's move on to Pentacam or into tomographic analysis. And tomographics is giving us front surface information, back surface information, thickness information, and we can look at that over time and things to see the changes that would be sensitive enough to screen out patients. And here's a 40-year-old, you can see a -6 with some cylinder, 2015, a little bit asymmetric bow tie, that'd be about a Randleman score of 1, which should be fine. And here, if we did an actual Pentacam, we could look at various indices like front elevation differences, back elevation differences, let's see if I can get this little laser. Progression index, which has to do with how much does the thickness change as you go peripherally, the thinnest pachymetry, and then an ambrosia relational thickness, which has to do with the thickness relation together with progression changes. Each of these individual things are statistically not significant alone, but in combination, if you come with a final D-score, you can actually see something that's statistically significant. And we typically look at where there's caution and where there's stop in terms of what you would actually want to screen a patient before you do surgery. And this patient was okay. Things are moving a little bit further even into biomechanical testing, and that's really not the premise of our talk today, but it's just to suggest that even in cases where it looks like it could be normal with that BAD score, you might find that biomechanically there's some things that suggest it's not. So you always want to look at the latest technology. But let's talk a little bit about the monitoring and progression for keratoconus in terms of cross-linking. Some of those indicators are essentially the same. I'm looking for early keratoconus patterns, steepest K, topographic change, and of course some of those advanced tomographic images. So topographically, it's really just more of a threshold of shape and progressive change, whether it's a screening issue or whether it's looking at progression monitoring for cross-linking. But how about when we look at Pentacam tomography? Is there something that's maybe a little more different that we can differentiate? And this just shows a little bit of the idea that the screening software with the Belin ambrosia is one particular thing that we do for the keratoconus monitoring for LASIK surgery. But there's now an ABC progression of keratoconus that's part of the software that helps us look at the monitoring for cross-linking decisions. And ABC stands for anterior, back surface, corneal thickness, and the D refers to vision as it screens that. Let me go further here. So here's just a case of what looks like an obvious keratoconus. And if you break it down, it'll give you metrics in terms of scoring systems and keratoconus staging for the anterior surface, posterior surface, the thinnest pachymetry, and also the best corrected vision, because vision has something to do with the losses involved with keratoconus. And this way you can stage a patient. You actually have to type in the vision in order to get that bar to come across and to give you your final metrics. And this just gives you a little bit of some of the different A, B, C, D criteria for stage 0, 1, 2, 3, and 4 keratoconus, which would be the criteria that you could use for advancing disease. You can then take those criteria and map it out in a progression display. And the progression display will again look at anterior surface with this first column. This is different time points. Posterior surface in this column, thinnest pachymetry, and even the best corrected vision. And of course, the oldest exam would be first for each of those categories. Then you go to the next exam, and then finally the newest exam. And you can see as time goes on, how is it changing? Now, you could probably just do that looking at maps individually, although you have a nice metric to look at that's quantitative here. But what's nice is they actually come up with different thresholds of risk of keratoconus and also the normal in terms of 80th and 95th confidence intervals. And those confidence intervals gives you more of a sense of, okay, we're exceeding what looks like normal and really moving into keratoconus, and that helps us to really show progression and show that it's the type of thing that indicates disease. You can also mark in this graph where the treatment is actually made. So you could say, well, here's where the progression was advancing, and then we did a treatment, and we can follow what's happening after the treatment. And then you follow. And so you can actually map it out so you have both the right and the left eye on a single screen to do quick screening and review of it. And just to give you some examples of patients that I've kind of been working with, here's a 30-year-old, early keratoconus, steepest K is about 50 diopters. Here you can see a little bit of, over the course of about a year, you can see there's a little bit of what looks like early progression to suggest that this is something that's advancing. It's about a diopter or so in magnitude. If you look at the actual screening tool with the ABC, you can sort of see where it started out here at a lower level, but it started advancing for the anterior surface, the back surface, and of course you can see a little bit of the thickness changing as well. It's becoming thinner as time goes on. And of course you can look at individual metrics that again confirm that was at least a diopter of progression over the course of that year. So this is somebody that should be cross-linked. Here's another patient, older patient. You'd say, well, does this patient need cross-linking? But it looks like obvious keratoconus. Is it advancing, or is that cornea stiffer now that the patient's older and they don't need cross-linking? So again, you can look at different maps over time and say, well, I don't see a lot of change, but if you use the scale, this patient actually had a cataract, and so I had two things to really manage. But the cataract surgery was done initially, and then afterwards you could see there was a little bit of a change that looked like progression as time went on. And so here's the cataract surgery, there's progression. We finally went ahead and cross-linked him, and he's been stable ever since. Here's a 20-year-old female. Again, steep K about 50.8. Certainly looks like keratoconus. This is the second eye of an eye that actually was more advanced. And so we did see some progression. We knew we needed to cross-link this one as well. And here was the pre-op or pre-cross-linking map. And these are 4 months, 7 months, and 12 months after cross-linking. What's nice is you can look at this also in terms of where it was before and then see some changes over time. And most of what you want to see is it's not progressing after the cross-linking, which is what you'd expect, is that it's stopped and halted the progression that otherwise would advance. So overall, in conclusion, ectasia risk screening is different a little bit than the progression monitoring. It's the same tools, but there's different ways of looking at some of those tools. Topographic indices of a Pentacam BAD score, basically excludes the very center of where the thinnest pachymetry and steepest area is, looks at the best sphere, and therefore uses that as a reference point to see the potential for keratoconus risk. With the ABC staging, it's basically looking at the radius curvature of that thinnest area and localizing that specifically to see the monitoring progression and how it advances. And then finally, the difference maps of the ABC staging of keratoconus with the confidence intervals takes it an extra level beyond just looking at individual maps and trying to do difference maps between them. And I think that's just one more tool that we can use to better assess our patients. So thank you for your attention.
Thanks, Ron. So maybe I'll just stay here and we can chat. Thoughts on how you're defining progression or deciding which patients to treat, Dick or George?
So I like the Pentacam, and that's what we, rely on as far as the topography instrument. And Kmax, while it's variable depending on patient fixation and the like, it's certainly been a very useful tool for me. And so that's one thing that I'll record and progressively look at serially. I also think the refraction is important, and so I'll look for changes in spherical equivalent with the patient shifting myopic in almost all cases, and I'll look for increases in refractive cylinder. And those are kind of my fastballs as far as looking for progression. And in those patients that we confirm progression, that is what lets us to treat the patient on label. So many times we do need to, have that confirmation.
Go ahead, George, if you want to add anything. George is going to talk a little bit about monitoring after treatment, but if we focus right now just on kind of the pre-op decision.
Yeah, I mean, Dick's summary was excellent. And this also, it's sort of the rule of ones. So as we may discuss, we are currently enrolling in the first FDA Epion trial for cross-linking. And when we have to show progression, we're really doing this based on a diopter of steepening. And this can be based on Kmax or SimK or your steepest K of the SimKs, or a diopter of worsening astigmatism, or half a diopter of, if you're going to look at the spherical equivalence, mathematically that still kind of works out. And so that's kind of an easy summary of progression and how to look at that. Kmax is very useful, but to Dick's point, it is quite variable. And we looked at this a number of years ago in some other trials. If you take 5 images of Kmax sequentially, you're going to have a large variation. So the trend has really been to do more of a zonal analysis when we're looking at trying to get a sense of progression, stability, or regression we'll talk about that a little bit. But that's kind of it's really sort of the general rule.
So, Ron, I think you also were describing how to differentiate this from screening for ectasia or risk of ectasia in LASIK patients or refractive surgery patients in general. How do you approach patients that have siblings or family members who have a history of keratoconus in terms of making a decision in refractive surgery?
Yeah, so obviously that's one of the areas that just heightens your attention to making a right selection for the procedure you want to offer. There are instances where you could look at what looks like a totally normal map, and I've even seen where the biomechanics might look good, and yet the ectasia can still happen. And so there may be something even biochemical that we can't even detect, even before the mechanical changes that we'd otherwise be looking for, and of course the shape changes. So if somebody has a sibling or a parent or something that had obvious keratoconus, I'm probably going to step back a little bit. I might be more inclined to recommend a PRK surgery because it's less structurally invasive, and it depends on a lot of factors that are there, especially changes over time, because that's one of the sensitive things you want to look for, and age is going to be a big factor there too. Or I might elect not to. And I can actually think of an instance where my fellow's wife, who was a neurosurgeon, wanted to have refractive surgery, but her father had obvious keratoconus. And she looked like a perfectly good candidate for LASIK or SMILE, and that would have made it really easy for her in terms of recovery. In the end, we did a PRK, and it was a little more conservative, and she just took off the time and had the surgery and did well. So you got to look at each case individually, but you use some of those clues a little bit, like a family history, and it's not even to say that if there's a direct link that she would be at risk, but why take the chance?
And maybe taking that a step further, again, either Dick or George, keratoconus patients, how do you counsel them in terms of their family members? Should they all be screened? Do you have them come in? What do you tell them to tell their family members? I mean, obviously we all agree that we want to diagnose keratoconus if it exists as early as possible for all the reasons we've talked about, but
We do tend to, we're asked that question more often than we would advocate for it. But the answer usually is that it's a good idea. And this kind of gets to the broader question of the genetic role of keratoconus, and that's widely debated right now. I think the more we learn about it, I think most of us would agree that it is multifactorial, that there probably is a genetic component to it with variable penetrance, but that the mechanical factors probably can outweigh genetic predisposition, and even in a normal cornea, we've had cases sent to us of identical twins developing keratoconus in the same eye at the same time, and so we do believe there is a genetic predisposition, and that there are decent genetic studies and markers now that can substantiate that. So we do think it's a good idea. We've also had these cases with family members that have had transplants from keratoconus without refractive surgery, and we had to counsel them and make these decisions, and we've passed on a few, and then we've gone conservative on a few as well. So I think it really is a case-by-case basis, but we consider that almost a pseudo-independent risk factor. So not quite an independent risk factor, but almost a pseudo risk factor. So we do keep that in the back of our heads.
Okay. And maybe, Dick, if I can ask you to change gears a little bit on this, how do you decide once you have demonstrated this patient needs treatment? Which eye are you treating first? How are you making the decision? And how do you counsel the patient in terms of their functional activities afterwards, what they'll be able to do?
So I guess, like I do with everything else, I almost always treat the worst eye first. And so I'll treat the worst eye first. And it depends on how you want to define the worst eye, as sometimes looking on topography, the worst eye topographically, the patient may be wearing a contact lens 16 hours a day and seeing grade, and the eye that doesn't look quite as bad topographically, they might not be able to wear a contact lens at all. So sort of the worst eye is not just the topographically worst eye, it's the functionally worst eye. But, you know, and the patient helps you decide that. So I tend to treat the first eye, you know, the worst eye first, basically.
And then in terms of getting back into contact lenses, scleral lenses, how do you guide them a little bit on that?
Yeah, it's, for me, it's 1 to 2 months, and when they can often get back into a contact lens. So.